Hello, welcome to another session of Digital Slide Review and Sign Out. We have an interesting case today, part of the Digital Anatomic Pathology Academy. That program, of course, is made possible by the Digital Pathology Association and Path Presenter, a joint venture which has made this product available to all of the Digital Pathology Association members. I'll just note that membership for residents and trainees is without cost, as is membership for interested parties from the developing low and middle income countries. So our case today is another carcinoma from the area of GYN pathology. It's a 56-year-old woman who has a prior biopsy showing endometrial carcinoma with squamous differentiation. On initial evaluation, doing this via the laparoscope, the surgeon noted an abnormal peritoneal surface. And I think this raises the question of what is the usual pattern of spread for endometrial adenocarcinoma? Well, you know, the most common circumstance is local regional. And so we see several cases every year where on operation or at the beginning of the operation, a vaginal or periurethral spread is noted and the procedure is aborted pending some neoadjuvant treatment. Spread to pelvic and periaortic nodes is very frequent, and hence the importance of doing proper staging. Most of these cases will involve lymph node staging, either by a sentinel procedure or lymphadenectomy. The next most frequent pattern of spread is via the peritoneum. Lungs, extra-abdominal organs, solid organ spread are much less common. But these first three are things that need to be concerned, the surgeon needs to be very aware of and concerned about in their initial evaluation and planning for surgery. So on entering the abdomen and seeing an abnormal appearance, they were concerned that they might be dealing with peritoneal spread. And so they biopsied several fragments of peritoneum. This is from one of the uterosacral ligaments. Most of this disease was prevalent in the pelvis. So let's take a look at what we have here, because this is a little bit of an unusual pattern. As we note here, we've got a lot of inflammation. We've got some granulation tissue-like structures. And then we have these little globs of eosinophilic material surrounded by cells and so forth. So we'll take a look a little bit closer at some of these. And as we come in on higher magnification, I think you can see that these have sort of a necrotic center with a little bit of preserved architecture. And in fact, you can see sort of the cell borders resembling squames with some engulfing giant cells in several areas. So looking around, it turns out that all of these viable elements are giant cells, and all of these eosinophilic areas are nothing but squames. Now note we also see here in the background some inflammatory cells and hemosiderin type pigment. So there's evidence that there's been some intra-abdominal blood of some sort, maybe endometriosis, maybe something else that's providing the heme products for breakdown into hemosiderin. We'll have one more higher magnification view of one of these. And you can see here that even you can almost identify the intercellular bridges in these little squame islands. In none of these, here very high magnification, you can even see the keratohyalin granules in some of these. In none of these did we find viable tumor cells. Now, in looking at the patient's endometrial carcinoma, oh, excuse me, this is the wrong slide. We want the next slide. We noted that the tumor was not very deeply invasive. It had a nice glandular formation throughout most of it. And we can see that gland formation would put it into the category of, grade 1. And areas of the tumor showed little clusters of squamous differentiation, such as right here. We can see a nice little rounded keratinized cell, a few others here associated with that. And then in a few areas, we see nice keratinized squamous epithelium here. And this is, I think, perhaps the clue here, we also see these little keratin pearls that are have lost viability. They essentially have become necrotic or completely hyalinized, keratohyalinized, and matured. Interestingly, many of these were down near the deeper portions of the tumor, not so much on the surface. And we'll show you one higher magnification view of one of these, again showing, this is in the endometrial cavity, showing the nice keratin squamous differentiation with these keratin pearls with loss of cellularity, loss of viable nuclear material, and you see the process going on here. So how do we explain this? What's going on here? Well, in fact, this is something that has been described for some years. It's not very frequently encountered, but these keratin granulomas have been described associated with a variety of endometrial lesions that can show squamous differentiation. So the most frequent of these would be endometrial adenocarcinoma, either in the uterus or the ovary, that had clear-cut squamous differentiation. But it's also been seen in atypical polypoid adenomyoma, something that's frequently characterized by numerous squamous morules, and thus I would think theoretically could also be observed in endometrial hyperplasia with squamous morules. Similar lesions occur with ovarian teratoma that may rupture, although I think in those circumstances the pattern of keratinization is a little bit different, and therefore one would expect the granulomas a little bit to be a little bit different in appearance. The pitfall here, of course, is that radiologically, if these are bulky or extensive, they can give some peritoneal impression on CT scanning that could lead one to upstage it. And the important bit of information from Dr. Scully's and Dr. Kim's series of 20 plus patients, as well as all the things that have been published since with smaller case series, is that this does not have an adverse effect on survival. And although some patients were treated with radiation on the basis of this, those without therapy had equally good outcomes. So this is a true pearl of pathology, one would say, peritoneal keratin granulomata that are associated with endometrial adenocarcinoma with squamous differentiation in this case, not upstaging the tumor beyond the pathologic stage 1A as determined on the initial assessment. So I hope that helps you. You've enjoyed that little foray into pearls of pathology and GYN. If you like this, please subscribe and you'll catch future releases from our channel. And we always welcome your comments and are pleased to hear from you either directly or otherwise. So until next time, thanks for joining us.